we make a small revision about some important topics that maybe come in the exam and in the real life. Our surgical objective is the causes of acute abdomen, surgical cause, and the differential diagnosis, and the most important point in history and exam. Also, we will maybe give some points to investigation and management for acute causes and management of surgical abdomen. First, the causes of acute abdomen may be due to intestinal cause, or hepatobiliary, or vascular, or urological, or gynae, or medical causes. So you have to know that acute abdomen, if you have to take a history and then you do exam, there are a lot of differential diagnoses. So the important point is about the history. What is the important point in the history? Then I will do physical examination related to the history, then I will order the investigation. Regarding the intestine, maybe the differential diagnosis is wide. Maybe the most common cause is acute appendicitis, mesenteric adenitis, mixed diverticular or perforated peptic or duodenal ulcer. Also maybe related to gastroenteritis or diverticulitis, intestinal obstruction or strangulated hernia. Also the other causes of hepaturia and vascular is important points, but today we will concentrate on some causes due to intestinal causes. Acute abdomen is classified regarding the origin of the abdomen pain. Maybe it's suprapubic or central abdomen, or in epigastric area, or in left or right side of the abdomen. So we have quickly good history about the region, about the site, onset, and aggravating or relieving factor. And then we maybe make a differential diagnosis depending on the history and the location of the pain. Most important, we have to concentrate on the site and the duration, as we mentioned previously, and the onset, and the character of the pain, and radiation, timing of the pain, and maybe we have maybe previous attack or previous surgical intervention in the abdomen. Associated history related to the GI may be related to bowel, last open, last surgery, bowel habit, diarrhea, constipation, bleeding per rectum, melena, and dyspepsia. Another causes may be due to gynae causes, or maybe due other causes like fever or appetite, weight loss, or distension. Acute abdomen examination. Every abdominal exam is built on by history. If we take a good history, we can make a good exam. We start by inspection after taking vital sign, then palpation, then percussion, and auscultation. By inspection, we look most likely for the distension or scars or asymmetry. By palpation, we start at the point of maximum tenderness. We start far away from the maximum tenderness. Then we start superficial palpation, then deep palpation. Also, we have to do percussion and auscultation for bowel sound to look for absent bowel sound or normal or hyperactive bowel sound. As we mentioned previously, the pain may be related to the site. So we have to know that these regions is classified to 9 regions. We have many differential diagnoses related to the origin. And right iliac fossa pain, as we mentioned here, maybe the causes may be due to appendicitis or pelvic inflammatory disease or pancreatitis sometimes, or ectopic pregnancy or neoplasm, diverticulitis, intussusception, and other causes for inflammatory or irritable bowel disease, or stones for urological causes. So, taking history, there are in right iliac fossa, we have examination, then we have order the investigation for suspected or most suspected diagnosis. And left iliac fossa may be due to sigmoid diverticular or urethric pain, maybe due to pelvic inflammatory or ectopic pregnancy, or maybe due to another causes and minor causes like torsion or ovarian cyst or pneumonia sometimes, and sometimes in colon cancer or stones. For acute abdomen, for epigastric pain or right upper quadrant pain, as we mentioned previously, maybe it's due to epigastric pain due to peptic ulcer, duodenal ulcer, or gallbladder diseases, like we mentioned here, maybe due to an epigastric region, due to epigastric due to stomach, duodenum, or gallbladder in this site, and sometimes maybe due to any injury to spleen or liver at the same side of the pain or maybe in the contralateral. Sometimes the gallbladder pain, gallbladder acute cholecystitis may be presented in the right shoulder and sometimes in the back. Okay, next. Okay, after taking history and exam, we will order some investigation. The investigation we have ordered is classified to laboratory, radiological, and interventional investigation. As we mentioned previously, with history and exam, we have to order a good laboratory investigation in the same blood sample. If we suspected for appendicitis, we have to order as a minimal for CBC and urine analysis and culture. And if it is female, we have to order for, especially for married, for ectopic pregnancy, and sometimes you have to order for sometimes your electrolyte. If the abdomen is in right upper quadrant, we have to order for CBC to rule out acute infection, leukocytosis, and we have to order for liver function test, total and direct bilirubin, and sometimes you have to order for PT-INR if there are elevation in total and direct bilirubin. Maybe if there are epigastric pain or lower or right upper quadrant pain, we have to order for ECG, and maybe we order for chest X-ray or ultrasound after laboratory investigation. Sometimes if there are distension and we suspect it for intestinal obstruction, we have to order for CT. Interventional procedures, we have to order sometimes it's endoscopy as upper endoscopy or colonoscopy. In the simple way, we have to start with laboratory, then with X-ray. The X-ray give us a lot of information. Maybe it gives us there are intestinal obstruction or dilated loop or fecal impaction or presence of a stone. It depends on the position or dilated loop or absence or presence of fecal material in the X-ray. This is an X-ray presented or a huge dilated bowel, most likely in small bowel obstruction. And this is presented the huge dilated small bowel and large bowel. As we see here, there are dilatation and gas, and there are some dilatation in the transverse colon also here. Also previously, we see that there are dilatation in small bowel and it's central located in the central of the abdomen, not in the peripheral. Because if there are peripheral dilatation, most likely it's present as a large bowel. If it is central in this area, maybe it's due to small bowel. If there are absence of air in the rectum and there are dilatation in the bowel, so there are distal obstruction which lead to cut off the stool or the gases. So there are absence of the rectum in this area. This is the most important point to use in X-ray. Sometimes we present with air in abdomen, maybe due to post-operative procedure, maybe due to perforation, cholangitis, abscess, or gallstones. As we see, there are also dilated bowel, and sometimes there are presented sign of volvulus and huge dilated sign of the bowel. If you see this the huge dilated bowel, and this is a huge dilated bowel. So an X-ray is important to see if there are a problem in the abdomen, or there are air under the diaphragm, or multiple air fluid, and there are maybe dilatation or volvulus. After we do an X-ray, and sometimes we have to do ultrasound or CT scan, we have to know that there are active intervention, know that there are urgent surgery, should not be delayed. The urgent surgery should not be delayed for time-consuming test when an indication for surgery is clean. The following three categories of general surgery problem will require emergency surgery: generalized peritonitis, or perforation, or a reduced bed and tender hernia. Because any delayed will lead to complicate the problem, lead sepsis, peritonitis, death in last. Management for conservative management for any patient who complain for abdominal pain and there are maybe decrease the risk for any surgery, we have to ask for weight loss, smoking cessation, alcohol reduction, exercise, and moderate. But if there are admission and there are active problem, we have to do airway fluid or secure airway, and to give oxygen and fluid imbalance. We have to do IV cannula, and we have to give analgesia, IV antibiotic, and thromboprophylaxis. And sometimes we have to insert NG tube and antiemetic, especially if there are intestinal obstruction, there are suspect of obstruction, we have to insert NG tube. Sometimes there are indications to do specific investigation. As example, in ERCP, we do ERCP in some there are obstructed jaundice due to impacted stone or sludge. Also, we have to insert NG tube sometimes in patients with suspected intestinal obstruction. We have to give antibiotic here because there are some patients who needed to have antibiotic sometimes in cases of acute appendicitis, acute cholecystitis, or there are maybe sepsis due to intestinal obstruction or suspected perforation. The management versus or the management of surgical management, the emergency laparotomy or wait for unweight. Sometimes some patients presented with some surgical causes that not need surgical intervention, sometimes as partial intestinal obstruction, or sometimes there are acute cholecystitis, but not there are indication for acute surgery. We have to monitor the patient, serial CT scan. Sometimes if the patient become unstable, we have to do surgery. Example, if the patient be inserted in appendicitis, some patients is not benefit for surgery. So we have to admit the patient, give medical management, then we optimize the medical condition, then we perform appendectomy or cholecystectomy. Some patients are not benefit from colectomy. So we have to do defunctioning ileostomy, or some patients there are abscess in the abdomen. So we have to do drainage of abscess. Some patients may be presented in the abdominal pain, but this pain is not at the same site. As an example, we mentioned previously, the abdominal pain may be presented in the right upper quadrant, but may be presented in the chest and may be presented in retrosternal or between the scapulas. So the acute cholecystitis may be presented in the shoulder, may be presented in the right shoulder, may be presented between or in the half of the abdomen. Also the ureteric, or sometimes some patients complain of testicular torsion, and they are presented with pain in suprapubic pain. So when examining the abdomen, we have to examine from the nipple, this is the starting point, till the mid-thigh from here. So we have to examine the genitalia and to examine the abdomen and examine the chest. So on examining of the abdomen, we have to start from the nipple till mid-thigh, This is important point. If any patient there are problem with defecation or impacted stool or intestinal obstruction, we have to do PR. This is an important step to do in examination. Sometimes there are specific indications to do CT scan, especially in some patients with complaining of abdominal pain, hypotension, or severe abdominal pain with hypotension, or severe abdominal pain with malignant hypertension, then become hypotension, especially in some cases of acute abdominal aortic aneurysm. There are aneurysm and there are problem increase in diameter of aorta, which impending rupture. So this is indicate acute surgical intervention. Some patient may be presented with a thrombus, and this is thrombus or cutoff of the flow of the contrast. So this is an indication of active surgical intervention with vascular surgery to open the tract and to have a good blood flow to the distal organ. Also, sometimes some patient presented with air under diaphragm. This is an indication of perforated organ, or maybe presented with maybe perforated duodenal, like perforated duodenal ulcer, perforated appendix, or gallbladder, or sometimes presented, as we mentioned previously, due to previous surgery like ERCP or previous laparotomy or laparoscopy. This is an X-ray for a patient complaining of distended abdomen. And this distended abdomen, there are multiple air fluid level with dilated bowel, and there are cutoff sometimes, or this is not picture up here, for fluid in the rectum. So this is an indicator of intestinal obstruction. Any 3 air fluid level, more than 3 air fluid level, is an indication for intestinal obstruction. We finish our presentation, and thank you for you all, and أتمنى لكم نجاح في الامتحان. الله يعطيكم العافية.